love patient care. So, when you go in with the big team, your attending's there, and you've got your whole team full of residents and med students. And instead of talking about the patient outside of the room, you are inside of the room and talking to the patient, and it's a conversation.
With patient-centered rounds, instead of your typical rounding like you might do at some other institutions, we do everything at the bedside with a focus on the patient. So instead of having a conversation about the patient somewhere else, you're going into their room with the team, as long as they're agreeable, and you're having the discussion with the patient, not about them, and discussing everything with them and their family members.
The attending will review everything beforehand. So they look at the labs themselves, they look at the vitals, notes from anything that might have happened overnight or in the past 24 hours. And the idea is that rounds is not meant for the presenter to convey information to the attending and be a reliable reporter, but instead turns it into more of a discussion about what to do.
There's like a little huddle outside of the room, making sure that the person on the team who will be conveying the information to the patient feels like they know the information that will be important to convey.
Now, patient-centered can mean a lot of different things. It can mean we're focused on the patient. It can mean patients included in the discussion. It can mean the patient's in the room. But for us, what patient-centered rounds means is that patients are part of the process surrounding and they're present for the discussion, and the discussion is centered on them and intelligible to them.
And going back to that growth mindset, if you're presenting an idea, the way it works here at Cincinnati, if you make a mistake, if you kind of stumble through the presentation, everyone's there to kind of help you through it and grow from it.
You're able to also educate the residents and the students with the patient. So for example, I had a patient who had a chronic trach that actually showed that tube to the med students, talked about her speaking valve and the process that took. And they learned a lot more from that than they would have just reading about what a trach and a speaking valve is.
Basically, it's kind of a conversation, and the resident or the medical student will go through all of that objective data using terms that the patient can understand.
You talked with the patient about their vital signs, what their numbers mean, what their lab work means, what their imaging means, all from the past 24 hours to kind of give them a face-to-face update. And then at the end, you kind of come up with a plan together with the attending in the room, the residents, and the patient.
You're assessing what the patient was telling you, how they are able to interpret that information, and then you are distilling really complex information for that patient at that time. And then you're making medical decisions with the patient at that moment in the room with them.
Instead of coming up with a plan before you even meet that patient, you're doing that with them. They have a say in their medical plan and their choices, and I think that gives a lot of power back to the patient.
Communication. So if you go and in traditional rounds where you're rounding at a table without the patient, and you talk about a plan and you're like, this sounds like a great plan. Then you go to the bedside and you're like, this is what we're doing, see you later. You leave that room and there may be a gap in knowledge and information where there wasn't a transmission of information appropriately.
Instead of spending 20 minutes deciding maybe what medication would be best for the patient, and then come to tell the patient that we want to start, medication X, and they said, oh no, I actually don't like that. I've tried it before and it didn't work. Well, we just wasted 20 minutes deciding that's what we wanted to do, when if we would have just talked to the patient initially, we would have found that out immediately. And it changes the way that we practice medicine. So I think when we explain on morning rounds that we're going to give another IV 80 milligrams of Lasix, and the patient says, is that the water pill? And you say, oh yeah, that's the water medicine that's going to make you pee. And the patient says, well, yesterday I was up all night peeing. And then the team can say, well, today, why don't we try to give the nighttime Lasix dose earlier so that you can get some more sleep tonight? And the patient says, that sounds like a good plan to me.
It is more of a conversation as opposed to a just formal presentation.
This is just a way of involving everyone in the care of our patients, most specifically the patients themselves. So they're not being talked at, but we're making decisions together in a language all of us understand.
It really allows the patient to be more involved in their care. They're more informed about what's going on, and they're also more informed about what the plan is moving forward.
There's a lot of questions asked, and there's a lot of answers from the team as a whole. And it's really, really cool. You have an opportunity to learn with your patients or teach with your attendings to both the patient and your medical students and other learners.
I think patient-centered round is beneficial for the patient because it allows them to be more involved in the decision-making process. They have more control because their voice is more readily heard. I think when patients are ill, whether that's physically, emotionally, mentally, it can be burdensome because they feel like they're losing some of that control. So if we're at the bedside with them making joint decisions, they regain some of that control.
The patient is able to intervene and interject to, make sure that we have the right history, or if we've got something wrong, they'll correct us. And I think that it really benefits the whole team because then every single person has heard the patient's voice.
Explaining really complex things to the patients that I've taken care of has been really, really important to see. Big diagnoses such as needing major surgeries for your heart or having a newfound mass that could be cancer. It's one thing just to say it in the jargon that we use, but it's a totally different thing to have your patient understand what it is that's happening to them truly.
When you don't do patient-centered rounds, you kind of forget about the really what's at the core of what you're talking about.
I found that patients really like it because they like being part of the process. It can be really frustrating as a patient when you just have people coming in and out all day, and it seems like you don't even know who's here for what or like what service each person is on.
I was really amazed at how much patients got out of us being present and having a dialogue in the room with them. Not just with them, but also amongst ourselves. And they really appreciate it a lot.
You rarely hear someone that's getting patient-centered rounds being like, I wasn't told this, no one explained this to me, and the doctors were in here for 30 seconds and then left. It kind of avoids a lot of those problems that can cause a lot of frustration.
They actually have done studies where they look at patients' perceived time that teams spend in the room when you have like the traditional rounding model versus patient-centered rounds where it's all done right at the bedside. And even if a team spends the same amount of time talking to the patient, going over the plan with them, if they do it in the style that we do here at UC, they actually perceive the team being in the room a lot longer with them.
I was highly skeptical when I first arrived in Cincinnati at how exactly this would work. And actually very quickly, I really fell in love with it. When it's done well and done correctly, patients really, really feel connected.
You think, oh, these patient-centered rounds are going to take forever. We're talking to the patients and we're telling them what's going on and we're, asking them about their stories, which, hey, it's what we're supposed to do, But B, it actually is quicker because you're involving the patient in that discussion. You're not going back and forth and back and forth. And frequently patient-centered rounds that are done well end at the same time or sooner than regular table rounds where we round about the patient, then we go see the patient, and then we talk about the patient. They're frequently, shorter or the same amount of time. And I think they're far better.
Despite our really long history of working toward this and continuing patient-centered rounds at UC, COVID drastically changed how we round. It had to. It did that everywhere. In 2021, one of the improvement groups that the Residency had was trying to figure out how to get our teams back at the bedside working with our patients. It started with an awesome group of residents, fellows, faculty, and even some students to truly think how we could get our teams back to the bedside. We realized that this work was a little bit bigger than we initially imagined. Instead of just getting back into the rooms with our patients on rounds, we wanted to start thinking about if we should really reimagine what patient-centered rounds should look like in the COVID-19 era. It provided us a really good opportunity to step back and really reevaluate and figure out how we could do this work even better. I'm really grateful to the New York Academy of Medicine and the ACGME who are providing some funding for us. I received the Jeremiah Barondess Fellowship in the clinical transaction last year, which comes with some support and funding for a 2-year project that really focuses on work that improves patient outcomes and the patient experience.
Do what's right for the patient in the room at that time. And once you leave, you've accomplished all your tasks. You're able to close the loop and then move on to the next person. It's really gratifying.